And welcome to the latest episode of the India at Harvard podcast, a speaker series where we attempt to bring some of the best, most interesting Harvard faculty members, alumni, students, researchers, and other affiliates of Harvard University onto this platform to talk about various aspects of India's growth, India's development, India's journey. And today, we are extremely excited to have with us Professor Vikram Patel, who's an academic, a psychiatrist, and most importantly, I think, a change maker. He's the Paul Farmer Professor and new chair of the Department of Global Health and Social Medicine at the Harvard Medical School. He also co-leads the department's Mental Health for All lab and co-leads the Global Mental Health at Harvard initiative. He's also been named the Time magazine's one of 100 most influential persons of the year. Also co-leads the Lancet Commission on Reimagining India's healthcare system, runs a great NGO called Sangath, and has various other, I would say, accomplishments and work streams that he leads and is participating in. But that should give our viewers a brief sense of Professor Patel's work and journey so far. But to get started, Professor Patel, if I could have you talk briefly about your journey so far, what has inspired you to do the kind of work that you do, and what's brought you to this stage in your career, and also, of course, please feel free to tell us about your personal journey also along the way.
Anirudh, thank you so much for the warm welcome. So I often think of my journey as having really three phases. The first part of my journey was as born in India, went to medical school in India. I went to an excellent medical school in the city of Mumbai, but was really not at all engaged with the broader concerns about the health of the poor, the underserved, the huge inequities and inequalities that existed in India. The training I received in medical school was incredibly clinical. It was really focused, as I think most medical training is, on giving the highest quality care to people attending this government hospital. But we really never got into questions about, for example, what about the people who don't get to the hospital? Or what about people who get to hospital extremely late in the course of their illness and therefore often encounter much worse outcomes? This was never really part of our conscious deliberations as we thought about what it meant to be a physician. The second phase of my career was really when I completed my psychiatric training in England. I again was trained in another really top class hospital there, where I was surrounded by large numbers of highly specialized individuals in all ranges of brain science, neurologists, psychiatrists, psychologists, and so on and so forth. And then found myself partly out of wanderlust, really. I still was not all that familiar with the concepts of community, public health, health equity, as I should have been. Even though by then I had begun to notice that most of the people who came for mental health care tended to suffer or experience all forms of social disadvantage. For example, they might be refugees, or they might be an individual living in a violent relationship, or just more commonly a more protean kind of disadvantage, that they were low income families that had fewer economic opportunities. I found myself in Zimbabwe as my second phase of my career, where I came face to face with a completely different reality to the first phase of my life, which was working in top level medical schools in Bombay and in London. And this was a phase where I discovered a context in which poverty was a dominating feature of the population's experience of social disadvantage, where HIV was another very prominent feature. I'm talking about the mid 1990s, where there were almost no mental health professionals. There were just 9 psychiatrists for a country of 9 million people, and of whom 3/4 who were foreigners like myself, didn't speak the local language, and were living and working in the capital city of Harare, which meant actually, I think there was just 2 psychiatrists for about 8 million people. There were more psychiatrists in the corridor where I had my office in London than there were in the entire country of Zimbabwe.
Entire country.
But also, this was a context where the biomedical labels and diagnostic systems and the way we conceptualize mental illness in medicine completely was completely alien. People in Zimbabwe had completely different, traditional, culturally informed ways of explaining mental health problems. So here I was confronted with a completely new world. And I had to therefore almost reimagine how I would address mental health problems in this completely new world. And to do so, I began to study the playbook of what was then emerging as the field of global health. Remember the field of global health, which is now very widely spoken about these days? Those words did not exist back in the mid 90s. The field of global health was largely inspired by the HIV/AIDS pandemic, which was then ravaging sub Saharan Africa, and by the notion of health equity as a driving goal of all healthcare systems, by the notion that people who were living with a serious health problem had an entitlement to receive the best quality medical care, and that health outcomes should not be determined by a person's social status or standing in society. Very, very fundamental rights-based ideas around how healthcare should be organized. I was deeply influenced by that. And so came the third phase of my career, which was to begin to embrace some of the ideas, some of the interventions, some of the principles that global health was developing within my specialty of psychiatry, with the core goal of reaching the unreached, of reaching the underserved, of addressing mental health problems from a population perspective. And that necessarily meant stepping out of the hospital, stepping out of narrow biomedical models of health and well being, and leveraging resources that communities had in order to promote their well being and mental health and to support those who were suffering from mental illness to recover. So I landed in India in 1996. I was always deeply rooted to India. It's still my home. It's still my primary home, I have to say, even though now I work at Harvard, I still have a home in India. I have a big research program there. Um, and for the subsequent nearly 30 years, I devoted myself to working in India. And not 30 years, it would be 20 years actually, from 1997 to 2017. And I built up an organization in partnership with others called Sangath, which became a kind of vehicle for us to begin to implement these innovative new ways of thinking about mental health, about understanding what shapes an individual's mental health, and most importantly, addressing mental health both from the perspective of prevention and care by using the medium of a community based research organization that could work in partnership with various sectors, but most importantly, the government healthcare system. So that's really, in a nutshell, the trajectory. Of course, as you know, in 2017, I was recruited by Harvard Medical School by Paul Farmer, who was then the chair of my department. Paul was an iconic figure in the field of global health,
He was.
much loved, not just in the US, but around the world as a champion of health equity and a rights based approach to healthcare. So it was an enormous honor for me to be recruited by him. It was a great opportunity for me to take my, I was at that stage in my career where it was a right time for me to step away from my, as it were, very India focused program to really re-engage with the broader intellectual disciplines that were contributing to global health and social medicine. And so in the last 7 years, I've been splitting my time between the US, where now I chair the department that Paul led, and India, where I have a large research program that continues to innovate in different ways to improve mental health care in this country.
Thank you, Professor Patel. That's very inspiring. So, Professor Patel, we want to understand some of these issues that you talk about, equity and getting into the underserved. But what we thought we would start out with is to really first understand the landscape for mental health in India and what is the state of current mental health. It would be great if you could walk us through what are the different types of mental health diseases or illnesses in India, and then if you could segment for us, what the breakdown is of patterns across, and of course there's so many. Please pick what is, coming to you this morning, but across geography, from urban to rural, from age, different socioeconomic backgrounds, castes. So lay out the landscape for us in India, 40,000 feet up in the air.
So, the first thing to say is that we must not conflate mental health with mental health problems or mental health conditions. Mental health is a positive state. It's a state of well-being, in which an individual can realize his or her own potential, cope with the normal stresses of daily life, work productively, and make a contribution to their community. There's nothing in that definition that suggests a deficit model or an impairment model. And so I think we need to be very clear in our language that mental health is something we all aspire to. There is no problem of mental health. Actually, the problem is when mental health is so seriously impaired by a range of different factors that an individual suffers mental illness. And in that way, all the features of mental health that you describe are therefore impaired in one way or the other. So let me constrain myself to the real question you've asked me is what do we know about mental illness in India? So I guess some of your listeners will not be aware of the range of different mental health conditions. And so it's important for me to emphasize that mental illness isn't one thing. Just like physical illness isn't one thing, there are a very wide range of mental health problems or conditions from the earliest years of life, conditions like intellectual disability, autism, and ADHD, to adolescence and young adulthood when conditions like depression, anxiety, self harm, and substance use, such as using substances like alcohol, opiates, to later in life when you have psychotic conditions like bipolar disorder, schizophrenia, and ultimately in late life, the emergence of dementia, which is really a neurodegenerative condition. So it's a very broad range of health conditions affecting humans across their life course. Each one has a very particular set of characteristics to do with how they present to the individual, what the risk factors might be, how you manage them, and what the long-term outcomes are. So it's just important not to think of mental illness as a kind of a single basket, because there are huge differences, for example, in the prevalence of these conditions, or what the kinds of needs are of individuals with these conditions, and very importantly, how stigma affects these different conditions. Now, to your point about what do we know about how common these conditions are and who in our communities are particularly at risk, we know quite a lot actually. And in part, this is because the government of India back in 2016 conducted what is India's largest population-based survey of mental disorders in adults. This was a highly sophisticated survey, so the kind of data that was generated are probably the most precise that have ever been conducted on such a national scale in India. This was called the National Mental Health Survey. I served on the technical advisory group of that survey. And what that survey in a nutshell showed is that roughly 10% of all the individuals, more than 30,000 adults were randomly sampled from around the country. About 10% of that sample were currently experiencing a clinically significant mental disorder. 10%. If you translate that into the adult population of India, about 800 million, that means 80 million adults in India today are currently experiencing a clinically significant mental disorder. And these are estimates produced by the Ministry of Health itself through the largest survey ever conducted. In children, the rates are slightly varying, but not that far off the 10%. So you could roughly say with 1.4 billion people in India, more than 100 million children and adults in India today are in need for some form of mental health support or care. The next question is, what are the most common mental health conditions amongst these 100 million odd affected individuals? By far and away, they're mood and anxiety problems, what we call in psychiatry depressive disorders, and a full range of anxiety disorders. Apart from mood and anxiety problems, the other prominent conditions are, in terms of how frequently they're occurring in the community, would be substance use problems, particularly alcohol use disorders. And in some parts of India, for example, in the Punjab and in the Northeast, you also have other substance use problems like the opiate problem that you hear about a lot these days. But perhaps the most devastating mental health conditions are the most infrequent of them all, which are the psychotic conditions, particularly schizophrenia, which probably people would consider one of the most devastating of all human health conditions. If you group all human health conditions together, schizophrenia would rank as one of the most disabling and stigmatized of all human health conditions. Now, the real number that matters here, Priyanka, isn't that 100 million Indians are living with one or another form of mental health disorders. The question to ask is what proportion of these individuals have either accessed or received some care from the healthcare system? And the answer to that question is shocking. It's about 10%. Let me switch that around and say that means out of every 100 million Indians who are living with a mental health problem, 90 million have neither sought or received care from the healthcare system. To me, this is the number that has driven my own work. It has been the single most important goal for me to address in the program of work that I've led with Sangath. The final part of your question has been about which subgroups are affected more. Well, again, because there's a huge range of mental health conditions, there isn't a single answer to that, because for every mental health condition, there are some differences, for example, in which groups are vulnerable. One of the most important subgroup differences for mental health conditions is gender. So we know, for example, certain conditions like mood disorders, anxiety disorders are commoner in women. Other conditions like substance use conditions, ADHD, and developmental disorders in childhood are commoner in boys and men. Another very important subgroup difference is to do with social class. Generally speaking, lower income groups have a higher burden of all mental health problems than higher income groups. And in fact, the National Mental Health Survey also shows that. Now, you might ask, why is that the question? Why is that the reason? It's a very complex relationship. It's bidirectional. We now know that growing up in conditions of disadvantage and poverty increases the risk of developing mental health problems for a range of different reasons, but also the vice versa. That is to say, if you're living with a mental health problem, you're more likely to experience economic disadvantage, again, for a variety of reasons. And so it's like a vicious cycle between social disadvantage and mental health problems. You asked me about rural urban differences. The National Mental Health Survey does look at that. There does seem to be some differences. For example, it appears that mood and anxiety problems are commoner in urban areas. But it would be important to say that there are these differences are small, and that these are overwhelmed by the large differences in the unmet need for care. That is to say, the prevalence may be high in urban areas, but access to care is much higher in urban areas. So even if the prevalence is slightly lower in rural areas, in absolute numbers, the numbers of people who live in rural India is far greater than in urban India. Moreover, access to care in rural India is much less. And therefore, the level of unmet need is far greater in rural India than it is in urban India.
Professor Patel, any interesting research around pre-COVID or post-COVID or during COVID that sort of accelerated any kind of state of providing mental health care that would be illuminating to share, or any patterns that we could understand, maybe around COVID or the last 5 years or 10 years around um, India, that could help us understand the state of mental health. Would be great to hear from you as well.
Absolutely. So COVID, affected the whole world. And so here, when I'm talking about COVID and mental health, I will not refer only to India, because what we saw in India actually was also seen in many other countries. And there's a kind of some really important messages about COVID and mental health. because they help us understand what we should or shouldn't be doing when the next pandemic hits. The first thing about COVID and mental health is who was affected the most. Contrary to what a lot of us thought would happen when the pandemic began, we thought older adults would be particularly badly hit because isolation, the lockdowns and the isolation that was consequent to the lockdowns was often felt to be more toxic to the well-being of older adults. It turns out that exactly the opposite happened. That in fact, older adults did remarkably well through the pandemic when you think about their mental health. The worst affected groups were young adults, especially those who were in the midst of their educational careers. They were the worst affected. And now, of course, in hindsight, we have very good reasons to understand why that was. But it's a message that applies across the world. The second important finding was that there was a strong association between poor mental health in the population and one very important external factor. Of course, as you might imagine, this was also related to the intensity of the pandemic at that time. But the single most important factor was the stringency of the lockdown. So if you look at global data, and I can vouch for that because I was in India during the first major lockdown that happened in March 2020, that the stringency of the lockdown, the suddenness with which the lockdown was announced, and the conversion of a public health crisis into a law and order situation was extremely damaging for population mental health. And so it's important to see that this is something we have identified across the world. I've been involved with some global initiatives looking at what we can learn about the pandemic and mental health by bringing together data sets from around the world. And the single most important driver of poor mental health has been the stringency of the lockdown. The moment you impose a lockdown, population mental health worsens. The more stringent the lockdown, the worse is the impact. And then over time, as the lockdown is eased, mental health returns back to what it was before the pandemic. The third thing to say, over time, the general pattern has been that mental health at the population level, mental health problems have reverted back to the pre-pandemic level. So there's something positive here. There's resilience that has been built in the population. The lockdowns have ended. Of course, very importantly, the vaccine has helped people feel more confident, has protected people from the worst outcomes of COVID. And so I would say we're pretty much recovered from the COVID, the acute effects of COVID and mental health. What is another very important message from the pandemic is how much we can do to support each other, and how the power of social support, of social capital in enabling people and communities to recover from what has been one of the most catastrophic health events of recent times. The power of social capital, the importance of social capital, I think has been recognized like never before. The importance of accurate information to make sure that misinformation that was so common during the pandemic is effectively targeted. The need for the government to play a very strong stewardship role in the management of the healthcare system. Today, there is a huge recognition of the importance of the government and of universal health coverage. This would not have been the same without the pandemic, I believe. And finally, the deployment of digital technologies. If there's been one huge transformation in the day-to-day way in which healthcare is delivered, has been the embracing of digital tools and technologies. Telemedicine is the most obvious one, but there are many other examples. In India, for example, the CoWIN platform, truly revolutionary. It's remarkable to have a digital platform that has reached literally hundreds of millions of people, that became the basis for the entire vaccination campaign. That is another example of fast-tracking technology. You have to ask yourself the question, if there hadn't been COVID, would we have had these incredible advances in the deployment of digital tools for healthcare? And today, of course, those digital tools are now being employed or thought about in a non-pandemic way for strengthening the whole healthcare system that Indians can potentially enjoy in the years ahead.
That's an incredible range of statistics I think that you shared with us, and we want to transition into the stigma piece of mental health and mental illnesses in India. But before I do that, I wanted to ask you, based on the statistics you were sharing about India, two pieces. One, how does this compare, given you've had a global landscape and global research that you've also done? How is India comparing to some of the other countries, both developing or both at similar, let's say, stages of development, if that seems to matter, or geography, whether it's South Asian countries, or whatever some points of comparison might be to place India in a larger global context? And second, if there's a time series trend here, of course, COVID, you've explained how that reverted, how we reverted back maybe to pre-COVID levels. But if you were to look at the last, let's say, 20, 30, 40 years, is the state of mental health declining, getting better, stagnant? So those two data points would be great. And then we can get into the stigma part of the conversation also.
So Anirudh, I can't say there is data for us to compare India with other countries on mental health during the COVID pandemic, in large part because we have almost no epidemiological or population representative data on mental health in India since the pandemic, broke.
But even
Y-
outside the pandemic,
Oh, outside the
even
pandemic, we do
outside the
have, of
pandemic.
course, outside. So,
Yeah.
certainly, perhaps one of the hardest metrics that is used to assess mental health at the population level is suicide mortality. So, over the last 2 decades, India has become one of the epicenters of suicide mortality in the world. India has about 11 or 12% of the world's population, but about, I think, almost a fifth or a quarter of all world suicides occur in India. So, India has a disproportionate burden of suicides. And also, importantly, those suicides are concentrated in young adults, unlike in the West, where you see suicide clusters in older adults. In India, it's young adults, and there are many hypotheses and theories to explain that. The most important one, I think, is because young people in India are increasingly aspirational. As you educate young people, they
Yeah.
begin to live in a globalized world where they have unfettered access to social media and the internet, and they see the opportunities and freedoms that their education and social media brings to them, they are confronted with a very harsh a real picture for many young Indians, not all, but for many young Indians. One very prominent example is the regressive attitudes on sexuality and relationships. We live in a country in India right now where the laws on being able to marry somebody from another religion are actually looking more and more medieval than they were even 10 years ago. And this is in a country where, young people are being told that they're living in a land of freedom and where they can embrace global attitudes and global ideas. But yet, when it comes to the fundamental question that any human being has as they grow into adulthood, the freedom to choose your lover is denied to you. So this is not a minor issue. I would say the reason why suicides are clustered in young adults is because young adults are being crushed by conservative social norms. And importantly, I say this not only from my own ethnographic observations. So, I've worked a lot in self-harm in India, and I have colleagues who've been examining why young people attempt to kill themselves. But even if I look in our neighborhood in China, back in the 1990s, China had the highest suicide rate in the world. And a lot of that suicide pattern was exactly the same as India. It was clustered in young Chinese and a lot in young Chinese women. Today, China has a suicide rate that is less than half of India's. And when I ask my colleagues in China, what happened in these 3 decades? Is it because there was a mental health program? No. The general consensus is it's the emancipation of women. Women were able to acquire the freedom to control their bodies, control the life choices they had, to control where they live, who they live with. And of course, that also applied to men, but China was always patriarchal like India, so men already had a lot more freedoms than women had. But women were able to get those freedoms. And so I think there's a lesson here for India to learn from. So that's one metric we have. The other metric is, of course, for the unmet needs for care. India performs pretty much in the same league as most developing countries. About 90% of people who need care don't receive it. And unfortunately, when you do receive care, the care is dominated by a very narrow biomedical psychiatric model of care, which essentially means that you need to see a highly trained specialist, oftentimes in a psychiatric hospital, and the likelihood is you will receive a medication or a prescription for whatever it is you came for. The kind
Yeah.
of comprehensive, holistic care that people with mental health problems need
Need.
is unavailable to the vast, vast majority. If you had to ask me the question, what proportion of people with a mental health problem receive evidence based care? That is to say, care that is built around science, that addresses their psychological and social needs in addition to the clinical symptoms. I would say it's less than 1%. And that is still a picture that prevails today.
Clearly, a lot of work to be done, a lot of lessons to be learned, and hopefully a lot of those learnings to be implemented on the ground, which we'll hopefully get to, I think, when we're also talking about the work you're doing and the research you're doing with your work in India. But we also want to talk about the stigma piece of it, because in India, of course, for many of us who hear about mental health, I can tell you one thing that I think, at least in my network today, personal and professional, the stigma, but the incidence of people talking about their mental health issues, I think, has started to become much more in the foreground now. But that might just be a isolated incident. So why don't you tell us a little bit about, from your perspective, what is the state of the social stigma in India today around these mental illnesses, and how is that evolving? How is that changing? Is it changing for the positive in certain cases, not so much in certain others? Tell us a little bit about the stigma piece here now.
So Anirudh, I can speak to from my own personal experience. When I returned to India from my travels in England, Australia, Zimbabwe in 1996, I remember, telling people I wanted to work. In fact, when I chose psychiatry as my specialty, most people in my family, my friends, they said you've done so well in medical school. You were a Rhodes Scholar. You can basically choose any discipline in medicine. By that they meant the high value disciplines. Like cardiology and so on. You choose
Yeah.
psychiatry. I mean, that has to be, that's a choice that medical students who couldn't get into, all the high value disciplines would choose. So, that was a stigma. That's a reflection of stigma. I remember when I returned to India, when I would tell people I'm a qualified psychiatrist, by then I had finished my training. Let's say, for example, I was at a social event. Typically, people would snigger in a slightly uncomfortable way. They would make remarks like, "Oh, I better be careful about what I say because you might be analyzing me." Stuff like that. And of course, in
Yeah.
the broader community, mental illness was equated with pagal. And in many parts of the country, that was really seen as being something that was a reflection of some, spiritual or bad omen kind of force. And at government, the stigma played out by the fact that the moment you talk about mental illness, they say, no, we got more important things to deal with. No time for mental illness. What is that? That's really not our concern. Plus, we have these, 30, 40 mental hospitals. That's where mental illness will be treated, even though, of course, we know that that's where most of the stigma for mental illness was produced. And let me turn to that. Why do I make that provocative suggestion? That the stigma associated with mental illness is not simply a reflection that people are stupid. That's often what we think about, right? We think that people have these ideas about mental illness because they're just ill-informed, and that the right way to actually correct that ill information or wrong information is give them more information that is correct. I totally disagree with that. What people think about mental illness is utterly and totally shaped by their real world experience. Because what is the real world experience back until the mid 1990s? The real world experience is that if you had a mental illness, the odds were that the police would cart you off to a hospital that was surrounded by high walls and locked gates that looked exactly like a prison, both outside and inside, that had
Yeah.
been built during the colonial period. And that once you went in, you lost all your freedoms. Even prisoners had more freedoms. At least prisoners would know when they would be released. But if you got taken to a mental hospital, your freedom was completely in the hands of a group of medical professionals. When you were there, you would be made to dress like a prisoner in a particular uniform, and more often than not, you would be half dressed or even completely undressed. You would sleep in rooms that had bars no different from a jail. And I've been to many of these hospitals, so I speak from first-hand experience, where 6 to 10 people, half naked, would be sleeping next to each other. I cannot tell you, Anirudh, it is the most shameful, the most humiliating, and the most painful experience of my life to walk into a mental hospital. And then when people tell me that stigma requires, campaigns with posters on buses and, actresses going on television and telling you, that mental illness is normal. I'm sorry. No, stigma requires you to address the human rights abuses that have taken place from times immemorial, right through to modern times, to people with mental illness. And so the change that has happened in the last 30 years has been immense. Today, when I tell people in a party I'm a psychiatrist, they actually want to ask me questions. They want to come and talk to me. They actually say, "That's so interesting." I have my brother, my sister. It's amazing. The
That's true.
difference is so dramatic. And so if you had to ask me why, it's the same with government. Today, the government of India is championing mental health. You see the word mental health in virtually every policy. You'd see mental health programs getting more resources. And so the question of why that has happened is really important. And in part, it's happened because of the move away from that very narrow psychiatric hospital based model of mental health, or rather mental illness care, to a more community based psychosocial model that embraces much more diverse perspectives on how mental health is shaped, what creates mental illness, and how mental illness people can recover when they're affected by a mental illness. I have found a huge change. I see this nationally at every level. I see it in communities, as well. And so this is a very positive sign, a very positive signal. I see it in the media. Back in the 90s,
Yeah.
mental illness in the media was, or in Bollywood, was oftentimes just perpetuating the stigma, was perpetuating negative stereotypes. Today, complete change, transformation. Today the mainstream media regularly carries stories on mental health that are compassionate, that are driven by science and the lived experience. And same can be said about Bollywood.
And has that also translated, since you mentioned this, I wanted to ask you, has it also made a difference in the choice of fields for medical practitioners now? So you mentioned obviously at your time of choosing, it might not have been in the top of the hierarchy, but is it changing as far as medical professionals are concerned and their choice to go into this field? Is it changing from a funding of research and proliferation of research programs? Is that also changing?
So I can't answer the first question empirically, because for that, what I'd need to know is how many people apply for psychiatric residencies, and what's the acceptance rate, right? So
Sure.
one reflection of an increased demand for a certain good is how many of those who need it or want it are actually receiving it. I can't answer that question because I don't have that kind of data. But what I will say is this: in India today, the way medical professional training is being largely driven is not by personal mission that much any longer. Sad to say, it's by the value that that particular specialty offers in terms of income. It's true in most parts of the world. Medicine has really become no different from any other business. It is in fact a business in India as much as it is a business in the US, and many young people are choosing those specialties that they perceive have a higher value when it comes
I pay off
in
over time.
economic terms, rather than whether you're necessarily doing something for the social cause or some kind of personal mission. And in that vein, psychiatry is definitely high value. I mean, I know every single psychiatrist I know is absolutely totally overwhelmed by clinical work. So that's a reflection of demand, and therefore and the scarce supply. There are only maybe 4,000 or 5,000 psychiatrists in India, which is a pitiful number. The psychiatry is a very, very attractive profession. So I think I wouldn't be surprised if it's attracting more and more of the younger graduates who are bright and making it their first choice, which is not the same as choosing psychiatry because your first, second, and third choices were unavailable to
We're
you.
not available.
Yeah, I believe more and more young people are choosing psychiatry as their first choice, but that's subjective a subjective
And
judgment
what about
rather
the
than an empirical
research?
one.
What about the research and
A lot
the
more,
kind of
a lot
emphasis
more.
on?
That I can tell you without any doubt, the research funding has definitely gone up, particularly within India. ICMR, the Department of Biotechnology, they both fund different aspects of mental health. The Department of Biotechnology mostly funds the more kind of basic science aspects, the neuroscience bases of mental health and mental illness. But the ICMR does more of the clinical and public health funding. But definitely far more funding than there was when I started. And of course, there's also the international funders like the NIH in the US are also funding a lot of global work in mental health, which they never did before 2000. And so that's also been a huge new source of funding. My own work, most of my work is NIH funded and in India. And so that's a reflection also of the opportunities for research funding. And another very important kind of funding you should be asking me about is government funding for mental health. And for sure, that has also increased. And so in all these ways, I see the metrics of political will improving. And so now is the time for us to offer the politicians, the healthcare system, and the community a different way of addressing mental health problems than what has historically dominated the sector.
Which I think is a great segue into maybe the work you've done as part of the Lancet Commission, right? Which, as I understand, was on focus on reimagining India's healthcare system. And I'm sure you maybe covered some of those learnings or findings already in the conversation we've had so far. But are there pieces out of that work that you've done as part of the Lancet Commission there that you want to share with us?
Yeah, absolutely. So there's a few commissions that I've led. I've led the Lancet Commission on Mental Health, actually on global mental health and sustainable development. And I'm now
Oh, good.
co-leading the Lancet Commission on reimagining India's healthcare
I think.
system. Um,
Okay. Yeah.
So, a few key messages, and a lot of this emerges from the work that my own colleagues in Sangath in India have been doing, but also work by global mental health practitioners and scientists around the world. The first thing is that we need to move away from thinking about mental health in a binary way. That is to say, what has dominated the biomedical approach is the notion that either you have a mental illness or you don't. Actually, most mental health problems are part of a spectrum. And autism is a great example of that. The autism community has embraced the notion of autism as a spectrum in which a particular domain of human functioning, the ability to socially connect with others, is affected. But it is not either it's affected or not affected. It's usually a question of what is the degree to which it is affected, and to what extent does that then influence your day-to-day functioning. It's a much more nuanced, a much more person-centered way of thinking about a person's mental health than simply boxing them into these kind of somewhat artificial and arbitrary categories that has dominated the field. What this opens the door to is the opportunity for both prevention and early intervention before a full-blown psychiatric episode occurs. And when you think about prevention and early intervention, it also opens the doors to deploying resources that are not in the medical system, in the formal specialized medical system. So one of the most exciting bodies of evidence that link to these 2 points, prevention and early intervention, have come from India. The first is the interventions that help alter the social environments of children and young people who are the most at risk to develop mental health problems when they face adversities by using parenting interventions. These are interventions that support parents to actually provide nurturing care environments for their children. There's a whole science behind that, but I won't go into that right now. But sufficient to say there's an entire body of work. And the great thing about these interventions is they don't need pediatricians, they don't need psychiatrists. These are interventions that can be delivered by Anganwadi workers, by ASHAs, by other frontline providers in India's healthcare system. And the second is early intervention. That is to say, when a person is developing distress, rather than wait for them to have an acute episode, you actually provide interventions in the moment. And those interventions tend to be focused on their psychological capabilities, their skills, or modifying the social environment in which that distress is occurring. As opposed to, let me give you an example. Typically, what happens right now is a woman is living with a violent partner. The violence is going on for years. She's very, very distressed. She goes up and down, up and down. And then finally something snaps. She attempts suicide. She lands up in an emergency room. Then a psychiatrist sees her and says, "Oh, you're depressed." And what does he offer? A prescription. Now, I'm not saying a prescription isn't important, but just think of this narrative. Here's a prescription, go back home. Now, I think anyone with any intuition can see that this is a deeply inadequate answer to what is a very
It's like a
complex
band-aid. Yeah,
person.
it's like a band-aid.
Yeah,
It's
exactly.
like
It's
very
like somebody
symptomatic, but
comes in
not
with a
going to the root.
It's like someone coming in with a same example. A woman comes in with a fractured arm because her husband has beat her. You just give a plaster, go back home. So I think this is not just true for mental health. I think across our healthcare system, we biomedicalize people's distress by ignoring the social determinants of health problems. And in mental health, it's particularly important because social determinants are often bedfellows of almost everyone's mental health problem. So the early interventions, what they do is they try and identify when a person is in a state of distress and addresses social and or psychological mechanisms to help them recover. And so it's a marvelous example of intervening in the moment and addressing what matters to the person. And all my work has really been around the using of community health workers, peers, and frontline workers to deliver very specifically designed brief interventions that target these mechanisms, running large randomized controlled trials that demonstrate how effective they are, and then, of course, working with the state, the government, to then figure out ways in which these models of mental health care delivery can be integrated in the state or national health missions. One more
Professor
thing I wanted
Patel,
to add.
in
Another very important
Yes.
point is that I wanted to add is, I mentioned earlier the profound abuse of human rights of people with mental illness in the mental hospitals. I wanted to add that another really important part, not just the stigma busting, but really enabling people with mental illness to live a life with dignity, involves
Yes.
engaging people with a lived experience in every aspect of thinking about how mental health care systems should be designed, how mental health care should be delivered, and how mental health care systems should be held accountable. And this is a deep personal philosophy of mine. And throughout my career, I have been deeply involved with supporting, mobilizing people living with mental illness to become advocates for their own cause. I was the founder of the Movement for Global Mental Health, which is the largest virtual network of people with a lived experience. There's a strong presence in India. And in all my research today, I actively engage with people with a lived experience to inform the work that I do and to make sure that the work that I do, importantly, is actually sensitive to their needs.
Professor Patel, just wanted to ask a question around shared values, setting the stage for the next sort of 10-year horizon. Do you feel that in India there is shared value across stakeholders right now, from government to medical institutions to private healthcare providers? Do you think that shared value is finally there to see sort of the aspirational goals around mental health? And can you just kind of tell us, the various stakeholders, what are their values right now in India going forward? What are the values around mental health for government, medical institutions, even corporate India? I mean, you're seeing a lot of these issues of anxiety, worry, depression, job loss, in amongst youth. So what are those shared values right now across the stakeholders?
I'd say, Priyanka, there is a huge convergence that is happening. The recognition that the narrow biomedical, psychiatry, medication dominated model of mental health care is inadequate is a global phenomenon. And India is not an outlier here. Okay, across the world, including in my own profession, I'm a psychiatrist. There is a general recognition that the paradigms that governed our field for 50 years have not produced the sorts of miracles that we see in other branches of medicine. I mean, let's be honest. There is no COVID vaccine in psychiatry. There is no, magical treatment for blood cancers as there is in oncology. We don't have any of those. And in part, there's a recognition that this idea that those very biomedical models that work so well for blood cancer, that work so well for tuberculosis, that it's inadequate to explain the complexity of mental illness, which is the result of a very unique individual experience that integrates or converges one's genetic heritage, one's early life experiences, and one's contemporary life experiences. No two human beings are similar when you think of the diversity of these experiences that shape mental health. And therefore, to try and create some kind of a one size fits all model that works beautifully for TB does not work that well for mental health problems. There's a global recognition that we need to be thinking in very different ways. And that's what actually, honestly, attracted me to psychiatry. What I loved about the notion of psychiatry was that it wasn't just a biomedical discipline. It was a discipline of medicine that embraced the social sciences, the humanities. Unfortunately, the last 50 years hasn't suggested that that has really been put into practice, but there is now a return to that. So today, for example, when the government talks about mental health care, they explicitly recognize the importance of frontline workers. The community health officer, which is a new cadre, in India's national health mission, one of their most important tasks is mental health. This is a person who is not a psychiatrist, not a psychologist. Typically, it's an Ayush doctor or a nurse who has completed bridge course training to become independently in charge of a health and wellness center. This is dramatic. When you talk to many of the providers who work in hospitals, they say they now have psychologists. They will have counselors, clearly broadening the range of interventions from a prescription to also offering at least psychological support. So I think change is happening. It's welcome. And I hope and look forward, actually, to much more of that change happening, hopefully, in a much quicker way.
Thank you so much, Professor Bird. That's very inspiring and very promising as well. And, we do want to mention that Sangath, it seems the nonprofit that you started 25 years ago is exploring this model of really bringing those frontline workers to provide the equitable and quality health care that is needed for these 100 million children that you talked about and the 80 million. I mean, in a country so vast as India, hitting a 1.4 population you need those community workers to get out there. So is this a scalable model? I know that, we read that it's now operating in Goa, in Bhopal, and New Delhi. What can we sort of expect from this model? Can it be scaled? What are sort of some insights that you're gaining from on the ground?
So Sangath is a non-governmental organization that works in very close partnership with state governments. It's got headquarters in Goa, but a big hub in Bhopal and a big hub in Delhi. But these are just physical spaces where teams work. But the governments it works with, for example, are Madhya Pradesh in Bhopal. And the model of scaling up that we've adopted is called Empower. Actually, this is a program that I also have at Harvard Medical School, which is doing the same kind of work in the US. So one of the exciting things about my work going forward is taking some of the innovations I developed in India and bringing it to the US, not something that happens very often in global health. Typically, the way global health is organized, things get developed in the global north and then get exported to the global south. Here, with Empower, we're doing a little bit of the opposite. But of course, ultimately, it's learning across context. And I think that's the beauty of global health and global mental health in particular, is that every country can learn from another country because health disparities and health inequities occur in every country. So the Empower model is a model where we take the interventions that are evidence-based, that we've evaluated in robust randomized controlled trials and shown that they work when delivered by frontline workers. We then use a suite of digital tools and technologies to scale these up by building the different kinds of content that are needed for frontline workers to learn these interventions, to then master these interventions, and then to deliver them for the rest of their careers. So it's a kind of an accompaniment model in which the Empower framework accompanies frontline workers to become skilled mental health care providers for their communities. Obviously, there are different interventions for different health conditions, and I go back to what I said earlier. There isn't one mental health intervention. So currently, we're scaling up a depression intervention in Madhya Pradesh. With the government's ashas, and soon we will expand to 8 districts where we'll integrate this with maternal mental health and early child development, bringing together the parenting intervention I mentioned earlier with the maternal mental health intervention. We're also working in 4 districts of South Asia, one in Nepal, one in Sri Lanka, and two in India, on scaling up an evidence-based intervention for children with developmental disabilities, particularly autism. And in this way, we're building up a library of different scalable interventions built on the science of what works. So, really, the sequence is you've got to demonstrate, first of all, that the intervention works in highly controlled settings. That's critical because people with mental illness deserve no less the best science than people with breast cancer or any other medical condition. I worry about those in the mental health field who say, you know what, we're going to do counseling without actually explaining what that counseling is. It's a little bit like saying, I'm going to give medication without explaining what the medication is. Actually, there is a profound science to counseling. The different approaches, some work better than others. And what we must demand when people say, we are doing mental health in the community, we've trained 1,000 workers to deliver counseling. The first question to ask is, what are they actually doing? And what is the science behind what they're doing? And what is the impact of what they're doing? Unfortunately, most mental health initiatives fall very, very short of that kind of transparent reporting. What Empower does is that it insists on science at every single step of the process, from which interventions we scale up to tracking every step of the frontline workers' learning and mastery journey, and then importantly, tracking patient outcomes to see what impact it's had on the people they have cared for.
Thank you, Professor Patel. That is very inspiring. We learned so much from you today. We got a really good understanding of the state of mental health in India, issues around equity and also quality care. Got some good statistics, really understood that shared value is really strengthening in India, and also some promising interventions around how to address the quality care, but also get to those numbers that you spoke about. We talked a lot about shared value, but would want to end by asking you your personal vision and your personal value and what would inspire you going forward, just in India in particular, what you hope to see going forward.
Well, Priyanka, my as it were, high level, hope and vision is that the change that we have been seeing these last decade or more will continue in a more accelerated way, such that no one who is struggling with mental health problems is denied the care that we know can transform their lives. I believe that India has generated some of the most important original knowledge that is informing the rest of the world. And I hope very much that our policymakers, our practitioners, and our communities embrace that knowledge, adopt it widely, and of course, when it comes to the government, resources it adequately for it to be scaled up to reach the last mile.